Look, thanks everyone for rocking up. I just want to put a bit of a preface to this. I think there might be a little bit of overlap from the previous talk, which was amazing. I've got a couple of extra notes here on dehydration. So I'm actually a little bit unapologetic for that as well. I think the more that you get to see some of these importance that come up in multiple talks, the better. So bear with me for that. But my name's Ben Amberg. I'm currently a bit of a professional student. I'm currently sort of in the last year of my PhD. So I did fourth year a few years ago now, but I've given a talk a few times. So hopefully there's a few things to take away from it. But kicked off. So meet Travis. So Travis is an 18-month-old 2-day history of significant vomiting. He's got a 4-year-old brother at home.
You're echoing a little bit. I'm not sure. It's only by like half a second.
All right. Maybe I'll just don't take my microphone out. Better?
Say something else.
That better?
Yeah, that's better. Much better. Thanks.
Wonderful. All right. So this is an 18-month-old with a 2-day history of significant vomiting, and he's got a 4-year-old brother at home with gastroenteritis. So what I want you to do is we probably won't spend too much longer than this, but we'll spend 2 minutes. Just kind of think to yourself, if this was the stem on an OSCE, what is the most likely cause of Travis's presentation? What do you need to know about the vomiting? And then what can't we miss? And what is going to be the end management? So just have a think to yourself, maybe scribble it down on a bit of paper. I'm keen just to stay away from the chat just a little bit. But the Muppets guys are doing a great job to keep an eye on that. So have a think. I'll just give you another minute or so. All right, let's kick on. All right, so what do we need to know? Straight off the bat, you've got a brother at home with gastroenteritis. This is most likely going to be gastro. But I think we mentioned before in the last talk that gastro is pretty much a diagnosis of exclusion. I think really important to think about, okay, so what sort of vomiting are we actually dealing with here? Is it possets and regurg, that sort of like tiny little bit of vomit that gets produced? Is it like real vomiting? And it's kind of what most parents will talk about when they talk about vomiting. Or is it your kind of like projectile vomiting, which is a little bit buzzwordy, but it's really like genuine projectile. And parents will often describe like it clears the baby's feet before it ends up hitting the bed. So what sort of vomiting are we dealing with? And then a really good question to then ask is, well, what's in the vomit? Is it sort of like milky, which kind of goes with that possets or regurg pattern? Is it the normal vomit, or does it have any sort of big red flags in it? Does it have bile or blood in it? So 2 really important questions to get straight off the bat when we're talking about vomiting. All right, then we think about what could it be. So you've got a baby coming in with vomiting. It could be infective. So it's going to come in with that classic history of fever, sick contacts, coryzal symptoms, and lethargy. And then that will sort of lead you down the track of like an infective type history. So we can't really miss things like the infections in the brain, the ear, nose and throat, the lungs, the gut and the urinary tract. And I absolutely encourage you all to have a bit of an approach to dealing with fever of unknown origin and screening each of those sort of main organ systems in your history taking. So it could also sort of be functional, which we sort of touched on in that last talk. Sort of it's going to be over a longer time course. It's more likely that sort of possety type vomiting pattern, and often is associated with some sort of urticarial type symptoms to go with that as well. And we're thinking those sort of things like gastroesophageal reflux, celiac disease, and cow's milk protein intolerance. Then this is probably where most of the talk today that I'll talk about anyway comes from is it something anatomical? Is it something that sort of needs surgical intervention? And so these sort of vomiting histories are going to present with sort of more of an acute time course. You might have the blood or the bile in the vomit. and the babies are often going to be much more stressed. And I guess the big one to look out for is, are they still able to pass stools? And that sort of comes in when we talk about some of the occlusions to the GI tract and some of the surgical management that will come in there. So we'll touch on some of these conditions: pyloric stenosis, atresias, interception, volvulus, Hershbrungs disease, and appendicitis. And then just a few kind of other causes of vomiting that can also be just nice to add in a couple of questions, just to sort of show that you actually, I don't know, have a bit more of a holistic approach to vomiting. Is like, have they had any head trauma? Is it sort of followed up with like an aura? So could this be like a migraine type picture in an older kid? And are there any sort of urinary symptoms to go along with sort of something like DKA? So I'll leave those there. So once you got, just to follow on with Travis, so you work out that Travis has a fever of 38.5. He's got no suggestive history of focal infection. He also has loose stools, so he's got diarrhea as well. It's normal vomit, so there's no blood or mucus. There's mild lethargy and tummy pain. He's had minimal to eat or drink, and he was 15 kilos at his last baby check 2 weeks ago. So that's the history. Very much falls into that sort of pattern of gastroenteritis. And so straight away you can be quite reassured that this is most likely gastro. The thing, I think good students will be able to pick up on gastro, and like when you're explaining to the parents what's going on and what the management will be, most people will get to gastro. I think really good students will then say, well, what else do we actually have to manage when it comes to gastroenteritis? And the key thing is dehydration. So this is where there'll be a little bit of repetition, but I really want to help you guys with taking a history of dehydration and then learning how to manage dehydration, particularly because it translates over really well to adult medicine as well. So when we take the history of Travis, you also need to take the history of his dehydration. So make sure we take fluid in, fluid out. Is just a really nice way to break that history up. So how much has he been drinking or feeding? And then how much fluid has Travis been losing? So diarrhea, vomiting, urine, and sweat are just a good couple of things to sort of gauge how much fluid has been lost. And are they still producing wet nappies? On examination, there's sort of a bit of a top to tail type approach. So you sort of think mental state, is he sort of lethargic or floppy? Is there a known weight loss? Now, there's really good guidelines, and that table that was up in the previous talk was really good. I actually think it's really good to have an idea in your head about sort of just from the history and examination, you can kind of gauge what percentage of weight loss the baby has likely to have lost. So if they have just a high risk history, so they've been vomiting lots, they've had diarrhea, but when you look at them, they're still kind of moving around, they're active, there's no real changes to skin turgor and things like that. If they have just the high risk history, they're probably about 3% dehydrated. If they have a high risk history and just a few clinical features, they're probably lost about 6% of body weight. And then if you're starting to get into that sort of severe dehydration affecting their mental state, that's when you're probably thinking, okay, now we're probably around the realms of 10% dehydrated. So obviously look it up in a table and things like that, but this is a really good guide just to think, okay, what sort of percentage is this baby going to be dehydrated? All right, so then you sort of continue on with your sort of normal clinical features, so capillary refill, skin turgor, vital signs, looking at their dry skin, sunken orbits, and their mucous membranes around their lips and on their tongue. But again, history examination is just kind of your standard approach to this sort of thing. Okay, so back to Travis. On examination, he's lethargic and floppy. He doesn't engage. He's had dry mucous membranes, reduced skin turgor. He's got the full works, and he's had no oral intake. It's obviously declined a fair bit since we did the first initial presentation. Again, maybe now that you've actually had a bit of time to think about some of the presentations or the management of dehydration, again, I'll give you sort of another minute or so just to think about how you're going to go about rehydrating Travis. So have a think, try and break it up into those areas. I think this has been floating around as some OSCE stations in the past. I think often they give you sort of like a calculate how much fluids you'd give Travis. I know you guys have got your own sort of online OSCEs. It's a good way to get everyone's heart rate up. All right, so we've got someone who's really quite dehydrated. How are we going to rehydrate them? Let's go. So management of dehydration. Now, this is one of the nice little ways to be nice and systematic about managing dehydration. There are pretty much 3 things that you need to consider for your management of dehydration. The first one is the route that you're going to be giving any fluids. What fluids are you going to use? And then how much under each of those banners. So if you can just answer each of these 3 questions for any clinical scenario, whether that's kids or whether that's adults as well, it's just a really nice way to think about them. So for kids, there are basically 3 routes that you can do it. Oral is obviously the best. So you can use water, oral rehydration fluids, or the breast. And as we sort of mentioned before, stay away from fruit juice, soft drinks, and sports drinks, really just to stay with either water or oral rehydration solutions, what we'll see most in hospital. And then the second line, and probably preferred to intravenous, is nasogastric tube. Now, really good, they've sort of shown that if you can slowly drip fluids down an NGT, it can actually settle some of the inflammation in the GIT. So it's actually preferred over IV rehydration. And then down the nasogastric tube, you can actually administer an antiemetic if they're really struggling with vomiting and things like that. And the one that we use in kids is ondansetron. The way I always remember that is ondansetron kind of sounds like a transformer. Just kids love transformers. So that's the way that you remember that ondansetron is the antiemetic used in kids. And then obviously third line therapy, if you really can't get an NGT and they're really quite unstable, that's when we're going to go to IV rehydration. So they're the 3 routes that you need to consider. So if we have Travis, who's obviously lethargic, floppy, he doesn't engage, we're probably going to be thinking for this kid, we're going to be using intravenous rehydration. To be honest, in most of your OSCEs and things like that, you'll probably either get an oral, a kid who's really well and just needs oral rehydration, or someone who's severe and you might need IV rehydration. All right. What fluids are we going to use? Again, there are only 3 that you need to know. The first one is normal saline, so just normal salty water. The second one is normal saline with 5% dextrose, so it's just a little bit of glucose added. And then there's normal saline with 20 millimoles of potassium chloride. So I'll go through when we use each of these, but basically there are just these 3 fluids that you need to think about at each of the different stages. All right, and then you've got to think about how much fluid you're going to use, and this is sort of what we touched on before in that last talk. So you basically need to consider, do they need a bolus? And then we consider the triple whammy therapy, not an NSAID, a beta blocker, and I don't know the other one, not that. Triple whammy rehydration. First one, okay, so the bolus, we give this to kids who present to the ED and you take one look at them and you're like, this is a sick kid. They're hemodynamically unstable. Their blood pressure is in their boots. Their heart rate is right up. And so this is when we're going to give them a bolus. The regime is, first of all, you do a 20 mils per kilo bolus. And then you reassess them. And if they're still hemodynamically unstable, you can give a second one. Probably the most important thing to know is just if they're hemodynamically unstable, we're going to give them a bolus, and the fluid that we're going to use is normal saline, normal salty water. All right, so then we move on to the triple whammy of therapy. The first thing that we need to do is replace the deficit. And if you think kind of logically about it, this is just replacing whatever they've lost. And it really comes back into that weight loss that we were sort of talking about before. So let's say that they've just, or in Travis's case, they're severely dehydrated. So you're thinking they've lost about 10% of their body weight. And the key for that is you need to just replace the grams that they've lost in body weight in mils of normal saline plus 5% dextrose. So you can, like I said before, you can do that with a known weight loss if they've had that on, if the mum knows their weight really specifically, if they've had a baby check, or you can do it off a clinical estimate like we sort of talked about before. and we replace that, the amount that they've lost in the first 24 hours. So with normal saline plus 5% dextrose. So I won't spend too long on the calculations, just because we did that a little bit before. The second part of the triple whammy is the daily maintenance fluid. So if they're not drinking any fluid, we just need to make sure that we give them what they need for the day through the drip. And we talked before about that 100-50-20 rule. So 100 mils per kilogram for the first 10 kilos, 50 for the next 10, and 20 for every kilo thereafter. So again, when we're replacing daily maintenance fluids, we're going to be using normal saline plus 5% dextrose. And then, so this is just a little example of Travis. So if he's 15 kilograms at his last Bailey check, this is the calculation for his daily fluid requirements. So it's just 100 mils times the first 10, and then 50 for the next 5. 15 kilos is bloody heavy for his weight, but just nice for the calculation. And then we've also got to add in for the first day, you've got to add in his fluid deficit, which is for that first day. So on the first day, he'll get his the deficit plus his daily fluids, and on the second day, he'll just get his daily maintenance fluids. All of that is with that normal saline plus 5% dextrose. All right, and then the only other thing that you need to do, and a really nice thing to add into the management plan, is that you're going to start a daily fluid balance chart and get the nurses to record or estimate, I guess, based on the nappies and any vomits, any ongoing losses. And so that you are going to be replacing any ongoing losses. So if the nurses on the ward think that they've had 3 vomits and that they reckon it's about 500 mils, over the you're going to replace that 500 mils with 0.9% saline with 20 millimoles of potassium chloride. So it's kind of like a little bit of an electrolyte replacement with the KCl. So look, that's just a bit of a whirlwind run through, but a really nice way to approach rehydration, just thinking about what fluids you're going to use and what are they actually going to be doing, particularly in kids in this case. All right, so that's hopefully the most common presentations of vomiting that you're going to see. What I'll sort of spend the last part of the talk now talking about is these acute surgical type cases. The good thing about having gone through rehydration now a couple of times, this will be really useful for all of your management of Peds surge, because every kid is going to come in dehydrated or will become dehydrated because they're going to go into surgery. And so you're going to need to be hydrating them as they stay in hospital. Okay, so whenever we get that acute presentation with bilious vomiting or bloody vomiting or projectile vomiting, the key is then to work out what is the cause and how can we treat it, because these guys do need treatment. Now, I will get to all the conditions eventually, I promise. But the thing is that you can actually get so much information and such a good clue about what the actual cause is, based on just taking a history and knowing which parts of the history are really, really important. So the first part of the history I'll point you towards, and for playing the MCQ game, this is an absolute goldmine, is how old is the kid? Now, someone ran me through this timeline as a student, and it holds up so nicely. So the first one is birth to 2 weeks. So in the first 2 weeks of life, it's always going to be something congenital, like something that was already there during development. So it's going to be something like small bowel atresia, malrotation, Hershbrungs, meconium ileus, and necrotizing enterocolitis. Everything after the first 2 weeks of life is going to be stuff that develops. So this is going to be in the first, from 2 weeks to 2 months, that's when pyloric stenosis typically presents. From 2 months to 2 years, that's when we're thinking about interception. Between 2 years and 5 years, that's when you start to get maybe interception, but typically kids with appendicitis. And then anything sort of after 5 years of life, you've got appendicitis, testicular torsion, and sort of late small Hershbrungs disease that presents sort of in adolescence. So like, bam, straight off the bat, you look at the age and you can get so much information about what it's likely to be. And if you think about the multiple choice questions, you're going to get all those surgical pathologies presented to you. And so you can rule out 90% of them just based on the kid's age. All right. The other thing is like, what sort of a history do they present with? And I sort of break these up into like an upper GI type history or a lower GI type history. So if you think of like a proximal picture, so this is going to be conditions like pyloric stenosis in the stomach, small bowel atresia, malrotation with volvulus or interception. This is when these kids are going to present mainly with upper type symptoms. So vomiting is the big one. Their main symptom is going to be vomiting. And then the investigations that we're doing, abdominal x-ray, upper GI contrast study, again, assessing that upper type part of the GI tract, and bloods looking for metabolic derangement because their small bowel is affected, and therefore absorption of nutrients is also going to be affected. So if that's their predominant picture, straight away you're thinking, okay, so it's something affecting the upper part of the GI tract, being the small intestine and the stomach. Or do they come in presenting with more a distal or a lower type picture, which is going to be presentations like incarcerated hernia, meconium ileus, Hershbrungs disease, or anorectal malformations. And the main presentation that these guys are going to come in with is abdominal distension. Yeah, because there's a lower type blockage, everything is going to back up and they present mainly with abdominal distension. They may have vomiting, but that's only when it's super duper severe to back all the way back up and affect the stomach. Okay, we can actually get a lot of information from an abdominal x-ray, and I don't claim to be a radiologist, but I think this is something you can straight away look at the abdominal x-ray and work it out. Now, on the left, we have an abdominal x-ray where there's something affecting the upper type part of the x-ray. On the right, we have a lower type picture. Now, the way that you can pick it, if you draw a line halfway through the middle of the x-ray, so basically at the level of the umbilicus, if all the gas is above the line, it's probably an upper type picture. So if you look at the one on the left, you can see that most of the gas is sort of up. And if you look on the right, most of the gas is down below the level of the umbilicus. And straight away, you can then pick, is this a proximal type problem? Is this a lower type problem? Just thought I'd share that. It's a nice way. I don't know, if you're on the ward, you can just have a look at it and think, okay, so now I know which part of the GI tract is genuinely going to be affected. All right, one more thing. I promise we'll get to the buzzwordy bit that will be the most useful soon. But again, I just think we can do as much of the legwork as we can for OSCEs and management and things before we get to memorizing the conditions, because I think the conditions become quite simple because you just need to know a few little details about each of them. All right, this one is just the classic surgical workup. I don't know if this is trademark patented, but I think I'll claim it. There are basically 2 talking things that you need to do, 2 oral things you need to do, 2 IV things you need to do, and 2 medical things you need to do for every patient. So the 2 talking things is you need to refer them to Paeds surge, and you need to explain to the parents what's going on, and do them in this order as well. The 2 oral things is you need to make them nil by mouth, and you need to insert an NG tube if they're going to be going in for surgery. The 2 IV things that you need to do is you need to cannulate them, so get secure IV access and make sure you've got some baseline bloods for them to go into hospital, and then begin IV rehydration if they need it. And then the 2 medical things, or we'll just say, bam, we already know this because we've done it twice this morning. And then the 2 medical things is analgesia and an antiemetic. So like, boom, there's like 8 marks that you can get in an OSCE, or like, to be honest, if we're thinking about just being good doctors, like if you can do those things as a junior doctor, like your job is not to know the surgery. Like our job is just to be able to do those things really well and have that on the plan so that when the surgeon comes and like, yep, they need to come into hospital, we've got that already sort of set out. And I think that'll be a big part of OSCEs in just making sure that you're safe and you can do these basic skills well. So 2 talking things, 2 oral things, 2 IV things, and 2 medical things straight off the bat. Oof, all right, we made it. Let's do the pathologies for the last sort of 20 minutes or so. So the way that I've sort of gone through is, again, I've got the little timeline about when these are going to present. And there are sort of like 4 major things that you need to know for each of these conditions. And we'll sort of go through them relatively quickly. just because I think you just sort of need to know a bit of a definition and how to manage them and some of the buzzwords. All right, so the first one we'll do is duodenal atresia. Atresia just means blocked lumen. So often when the duodenum's developing, they think that during sort of embryological development of the gut tube, there's sort of some vascular abnormalities or some incomplete formation of the duodenum, and it ends up blocked. I think it's simple as that. So 80% occurs below the level of the ampulla of Vater, and so you end up with this complete blockage of the lumen. Sometimes a small amount of gastric contents can pass through, but often it's a complete blockage. So the clinical picture is, and I think this is the buzzwords are sort of all in yellow for you, is the well-bilious vomiter. Well being that, like, because it's just a congenital blockage, like food just goes in and then it hits the lumen, but there's no sort of like hypoxia or incarceration or anything dying or anything. And so the food just hits the blockage and comes back up and they vomit it up. And because it's below the level of the ampulla of Vater, so where the biliary secretions come in, the bile comes up with it and they vomit it out. And the nurses like freak the shit out because they've seen green vomit. And they come running to the team, and I mean, it's a big deal because they need to go in for surgery. But the baby's sitting there fine because nothing is dying or under any sort of major stress. There's some big associations with Down syndrome. I think we had this in a previous OSCE, and there was some counselling stations about Down syndrome as well. So obviously you're going to be doing a full blood examination. When you do an abdominal x-ray, you see this sort of very typical double bubble sign. Comes up all the time on the good old MCQs. So the double bubble sign, what it basically is this is just an abdominal x-ray. You can see the first bubble is the stomach. And then you can imagine that the duodenum's got a blockage in it. So that first part of the duodenum also bubbles up as well. So you end up with a bubble in the duodenum and a bubble in the stomach. And that's that classic double bubble sign that you see on the abdominal x-ray. You can consider running an abdominal contrast study, but to be honest, a well-bilious vomiter with a double bubble sign on x-rays, getting admitted straight away for surgery. Then the management, this is where all that legwork that we've done so far comes in. Like, bam, you're going to do your baseline surgical workup. So that's like your 2 oral things, your 2 IV things, your 2 medical things. Forgot them. Anyway, the other 2 other things. The other thing that you need to do then is the surgery that they're going to come in for. This one comes up a little bit, is the surgery name is just a duodenal gyrostomy, which basically just means they take the piece of the obstructed duodenum out and they suture the 2, or they anastomose the 2 components back together. So I think if you could list off your basic surge management and the surgery name, and then say that they would be getting post-operative follow-up, that's like all that you need to know for duodenal atresia, and particularly for most of these surgical conditions. All right, so that's duodenal atresia, and again, because it's a congenital problem, it's going to be presenting within the first few days of life. All right, the next condition is it's called malrotation with volvulus. And again, this is sort of a congenital type issue, and so it's going to be presenting in the first few days of life, but potentially up to 2 weeks, and I'll sort of explain why that happens. Now, so hopefully you'll have a copy of these slides after, so you should be able to go back and have a look at some of the text. But basically what happens is during embryonic development of the gut, what actually happens is the gut sort of twists around within the abdomen, and that sort of establishes that that mesentery that we spent so long learning in anatomy back in pre-clin years, that I still don't quite understand. But it basically establishes this nice broad mesentery that sort of attaches to the posterior abdominal wall. And so what happens is in these kids is that rotation doesn't actually happen during embryonic development. There's a picture here for you if that helps visually inclined people, but that rotation doesn't quite happen. And the mesentery that attaches to the posterior wall is really narrow. And so what actually can happen is instead of the whole gut or the whole small bowel, can actually twist on that sort of narrow-based mesentery. And all of a sudden, once it starts to twist on the mesentery, it sort of starts to occlude major blood vessels supplying the small bowel. And that's when things can start to get really serious because the gut starts to die. So in a nutshell, when it comes to malrotation with volvulus, these kids are born with this congenital narrow mesentery. And so for the first few days of life, there might be little malrotations where it starts to occlude. And so they might be sort of irritable. This is just a picture of that mesentery as I was talking about, and it eventually starts to twist. But the clinical presentation is that they can be sort of irritable. And then what happens is as that you get that big twist of the small bowel, it occludes and all of a sudden you're blocking the lumen of that small bowel. And so then they start to become really quite unstable. And so the volvulus occludes the gut lumen. They start to vomit up some of the bile and they start to get this really acute sort of bowel obstruction type picture. So for kids who are sort of presenting with the bowel obstruction picture, they often have they draw their knees up to their chest. They're really, really distressed and uncomfortable. Once it starts to get even more severe, they can start to get sort of blood that starts to come out in the stools. But again, because this is a small bowel type picture, they're going to be vomiting. And the key is that this is the unwell bilious vomiter for malrotation with volvulus. All right. When we look at the investigations for malrotation, obviously you're going to get bloods as part of that initial management. You can do an upper GI contrast study or an abdominal x-ray. I think the buzzword for this one is the corkscrew appearance. So you can sort of see here, they've given contrast down into the stomach, and you can see the stomach and the first part of the small bowel is kind of twisted. And apparently that is meant to look like a bit like a corkscrew where the contrast is sort of trying to get down into that last part of the small bowel. But that's sort of what it starts to look like. So the management with this one is going to be those 8 basic surgical workups. The procedure for these guys is called a LAD procedure, where they have to cut the sort of occlusive narrow mesentery, and then they reattach the mesentery onto the posterior abdominal wall to make it nice and wide and prevent those rotations happening in the future. So there's a picture of that there. So they have to untort the small bowel and then cut the mesentery and then re-establish it. How are we doing for time? Beautiful. Ticking along. So the next condition is Hershbrungs disease. So we'll touch a little bit on Hershbrungs. Presents within the first few days of life. Again, this is a congenital problem, and it's sort of to do with development of the large intestine. So particularly the last part of the large intestine. I mean, sometimes it's called distal colonic agangliogenesis. To be honest, I think it's just someone showing off. But Hershbrungs disease, really when the myenteric plexus, those nerves that sort of maintain spontaneous contraction of the muscle in the large bowel, when they develop from the upper part of the bowel all the way down to the distal part of the bowel. In Hershbrungs disease, the distal component is just incomplete. And so you end up with a variable portion of the last part of the bowel that doesn't have any of those myenteric nerves to allow stools to move through. And so what you end up having, you end up with a sort of like a flaccid piece of bowel at the end. And so what can actually happen is stool can accumulate proximal to that piece of bowel, and it can cause sort of major distension. And you often see this megacolon mentioned sort of, I guess, as one of the major complications. There's a bit of an association with Down syndrome. So sort of just keep in mind duodenal and Hershbrungs disease we've seen associated with Down so far. This is what I was talking about before. You end up with this really dilated proximal section in the bowel, and then you end up with this last piece that has sort of like no hypertrophy and none of those ganglion cells or those myenteric plexus cells in that last part of the bowel. So clinically for these kids, the biggest presentation that these guys present with is they fail to pass their first stool. So in particular, so that's the meconium is that first stool, and they don't pass that. Normally we aim to see them passing the meconium within the first day of life, but what can actually happen is they can get to 2 days of life and still not have passed their first stool. And so that's a big red flag to have a look, particularly for Hershbrungs disease. And that would be quite closely monitored for most babies on the ward. So again, it's a bit of a spectrum. You can have really severe cases where the aganglionic piece of bowel extends quite a long way up the small bowel, or you can have a small section. And I guess obviously smaller sections are going to present much later, they can present later in life with kids with constipation. But this is when we talk about ped surge, it's probably kids with quite a severe large piece in that large bowel. Clinically, I mean, this is probably a bit almost academic now. The PR, when you do a PR exam on these kids, they have what's called a squirt sign, which is a bit gross, but it's basically just like you see unloading of the bowel when you perform the PR exam. This is just a little kid with a really distended abdomen. Don't think he has Hershbrungs disease. He might. But the main thing that they present with is distension of the abdomen as the fecal matter starts to accumulate. And they fail to pass their meconium within the first 24 hours. So the major investigations for Hershbrungs disease, the gold standard is a rectal suction biopsy, where they just insert a small catheter just into the rectum, and they take a sample of the bowel, and they look for the absence of those little myenteric nerves. And then I'll just go to the management. The management is basically what they do is they cut out that aganglionic section, and then they reanastomose the bowel up to the rectum, and that procedure is called a pull-through procedure. So, so the next one is necrotizing enterocolitis. This is a terrible condition, affects quite a lot of preterm infants. And so it often presents within the first 2 weeks of life. Now, there are basically, when we talk about necrotizing enterocolitis, there are two basic components to it. We actually don't know much about this condition. So the first place is you have a necrotizing piece of bowel. So you have a piece of bowel that is dying, and the colitis part insinuates that we have an infective component as well. So we know that there's infection in the bowel, and that bowel is dying and undergoing necrosis. Other than that, there's sort of less known about the pathophysiology, about why it happens. Two of the major risk factors, and I think you guys would see in multiple choice questions a bit, is that they are premature. We know that's a big risk factor, and often formula fed is also a risk factor as well. And they think that has immune related effects to it as well. So this is really dangerous, really high mortality rate, and needs emergency surgery to remove that necrotizing piece of bowel, to prevent sort of further complications. So because this is a large bowel type condition, they're going to present with that sort of bowel obstruction type picture. You have inflammation in the large bowel. When you do the abdominal x-ray, you're going to see that distal type picture with lots of gas backing up through most of the bowel, and see lots of distended bowel loops below the level of the umbilicus. But they're going to have that sort of septic-like picture where there might be fever, vomiting, the diarrhea might happen, but it also could become bloody because you've got necrosis and damage to the bowel. I think this is probably the buzzword that comes up a bit for necrotizing enterocolitis, is because you have necrosis happening in the tissues, they develop this metabolic acidosis because all that lactate ends up in the blood, and they end up really, really quite sort of hemodynamically unstable, but also metabolically unstable. On an abdominal x-ray, you see this sort of buzzword called pneumocystis interstitialis, which is really just, instead of seeing these nice clean bowel loops, you can start to see, particularly on the left-hand side, just near this monitoring, you can see some gas that sort of starts to enter into the wall of the gut, and that's sort of related to the infective component. So metabolic acidosis and pneumocystis interstitialis, two really good buzzwords to remember for necrotizing enterocolitis. The management, again, we wouldn't be expected to know too detailed management, but that basic surge workup, really, really high yield here. And then I think just important for us to know that these guys are going to need broad spectrum antibiotics immediately. So there's going to be Ben-Pen and Gent, and then you're going to be referring them to ped surge sort of immediately. I've just got a little note there about some of the complications ongoing for these babies that do survive. So chop out syndrome is basically where you remove such a large part of the bowel that they struggle with things like absorption and nutritional deficiencies. And so it's just important, if you had a counselling station for these guys, it would just be important to know that these guys are going to need long-term follow-up with Paeds surge, but also with probably nutrition dietetics for nutritional sort of advice. All right, so these get sort of progressively less high yield as we go through. I think this is probably one of the more important ones that often comes up in MCQs and OSCEs. So pyloric stenoses. Now, we're starting to move away from those sort of congenital ones and starting to move into things that develop over the course of the lifetime. So pyloric stenosis is sort of like a thickening of the muscle at the end or in the pyloric sphincter, so the last part of the stomach. And so we start to see that in the 2 weeks to 2 months of age, they start to develop this sort of gastric outlet obstruction, and they start to present with projectile type vomiting. It's probably the biggest buzzword you'll ever see in medicine is projectile vomiting and pyloric stenosis, often because it holds true when you actually have a look at kids on the ward. So projectile vomiting, and they vomit so much that they start to vomit up lots of their stomach acid, and so they develop an alkalosis because they've lost the hydrochloric acid from the stomach acid, but they also develop an electrolyte imbalance because they're constantly vomiting and losing fluids. So they develop hyponatremia, low sodium, as well as low potassium as well. So hyponatremia, hypokalemia, and metabolic alkalosis is quite pathognomonic of pyloric stenosis. Just a little bit of a picture. This is the stomach. So we're mainly dealing with that last part of the stomach, that pyloric sphincter. You talked about this a little bit. So they're presenting with that sort of projectile, and it's mainly milky type vomit. So it's never sort of bile stained, often because that obstruction occurs above the level of the antler vata. So it's mainly just going to be they get fed, often it's milk, and then they vomit almost straight after feeding. But again, because there's no sort of necrosis or inflammation in the wall of the bowel, they're often quite well. So they vomit up, and then they're still hungry, so they feed again, and then they vomit up again. So again, this is the well milky vomiter in terms of their clinical history. So it's just a picture of a baby so they have this sort of prototypic mass at the end of the stomach, and often you can sort of feel the mass on palpation of the abdomen. So investigations, it's a clinical diagnosis based on the history and the pattern of the vomiting. I mentioned before that they develop that sort of kind of prototypic hypochloremic, hypokalemic metabolic alkalosis. It sort of goes along with the low sodium and the low potassium from all of that vomiting that they do, as well as the loss of the stomach acid. And I think the best test for this one, although it is a clinical diagnosis, if you're a little bit unsure when they present to the hospital, just again, stay really as non-invasive as you can. An abdominal ultrasound can sort of give some evidence. These guys sort of sometimes end up with an abdominal x-ray where the main thing that you start to present with is really large distension of the stomach only. And that sort of leads you towards, okay, so there's nothing really in the small bowel. There's very little gas in the small bowel. And so we're really thinking that this is sort of something above the level of the duodenum. This was just a picture of an ultrasound because I just thought, who the hell can understand ultrasounds? But apparently you can diagnose pyloric stenosis with the ultrasound. All right, so the management for these guys, again, is that baseline surgical workup, and the name of the surgery for these guys is a Ramsted's pyloromyotomy. And so what they do in this procedure is basically just perform a little nick in the muscle of the pylorus, that pyloric sphincter at the bottom of the stomach, and that's been shown to just help break some of the muscle And then once it sort of starts to re-heal, it stays nice and thin and helps to relieve the obstruction. So it's not an emergency, but you just need to make sure that they hydrated and fed appropriately until they can get in for surgery. All right. I think this will probably be the last one. I don't really like rushing through the end of them, so we'll just go through interception and then we'll leave it there. So for interception, presents, again, this is a condition that sort of develops over time. It's not really congenitally related, so it presents from 2 months to 2 years of life. And basically what it is that you have a proximal piece of bowel that starts to sort of the normal peristaltic movements starts to sort of consume the next piece of bowel. So they call it telescoping of the bowel. And so what ends up happening is the little piece of bowel that gets incorporated into the proximal piece ends up being obstructed, and all the little blood vessels that start to supply it start to get occluded, and then you can end up with a little bit of an obstructive, sort of infarctive type picture. So 90% of cases are idiopathic, and they think it might be to do with the Paeds patches, or those sort of like immune lymphatic type pieces of bowel that sort of get swallowed up by the proximal piece. But in 5 to 10% of cases, there's like some sort of pathology that ends up leading to interception, like a Meckel's diverticulum or a hemangioma, like a clot or something like that, that ends up being a lead point where the proximal part of the bowel sort of swallows up the lead point. So this is just a picture of that telescoping type effect that I sort of mentioned. That down the bottom, there's a nice picture of a tumor in the lining of the bowel acting as a lead point. But the key is that piece that gets sort of swallowed up sort of starts to obstruct and become infarctive. The buzzwordy type presentation is because, again, this is often in the lower part of the small intestine, or sometimes lower part of the small intestine. You can start to get some blood that sort of accumulates distally and then can be passed. And so the red currant jelly stool, which looks a bit like this, I won't harp on that for too long, is really quite gross. But that buzzword does come up a little bit. And that's often an indication of quite progressive infarction in the bowel. That can be quite nasty. There's a clinical feature of a sausage-shaped mass. So apparently you can feel like a distended piece of bowel. To be honest, I couldn't find an image, so I just drew a sausage-shaped mass on this very unwell-looking baby. But sausage-shaped mass comes up a little bit on MCQs. Finally, just some buzzwords from investigations. The crescent sign on the abdominal X-ray and the abdominal ultrasound can show a target sign. I think this would be one of the few ultrasounds that you might be able to pick if you were told. Apparently that looks like a target, because I think it's that sort of telescoping effect of the bowel. But the best investigation for these guys is called a gas enema. So they basically add air or gas to the large intestine, and that goes basically back up the large intestine and sometimes into the distal small intestine to help relieve that sort of telescoping effect. So again, if you are planning the management for these kids, again, they're going to get that baseline surgical management like we've talked about, and a gas enema reduction is probably the best thing for these guys. Just a little note here that resolves in 75% of cases, but can sometimes reoccur, sort of in the remaining 15%. And in those guys that it does reoccur, sometimes you can do surgical correction to remove a rather nasty piece of bowel. All right, the last one I mentioned got there is just on the issues with the testis. I probably don't want to harp on that one too much. I left it sort of just at the end, just in case we had time, but I'll leave you guys to sort of look through that in your own time. But I just wanted to say, I want to show this last slide too. Thanks. I wish you guys all the best of luck. I'm going to be coming back into 5th year next year. So if you see me on the ward all by myself, please be my friend. It's been a while since I've been to med school, so it'll be nice to see you guys next year when we can see each other face to face. But good luck with exams, and hopefully I'll see you guys soon.
Thanks so much, Ben. That was fantastic. I'm sure you'll have lots of friends next year. Don't worry. Okay, guys. So we're going to have a break until